All right, we are in Module 7 now. We are in Chapter 13 today, and we're going to talk about asthma. All right, so I want you to look under obstructive lung disease, and specifically asthma on page 301. No, 300. All right, so there's periodic episodes of severe but reversible bronchial obstruction in a person who is hypersensitive or hyperresponsive to certain antigens. And we talked about antigens a little bit in the other chapters. So let's look at the patho. It's acute or chronic in nature. There's two basic types. There's extrinsic. This is from a type 1 hypersensitivity reaction, like we talked about in Module 4 with anaphylaxis. And there's intrinsic. This one is usually adult onset. There's hyperresponsiveness from infection, drugs, cold, exercise, an inhalation of some irritant, but you can have a combination of both of these at one time. So here are three important changes that we see in asthma during an asthma attack. You're going to have the mucosa inflamed and edematous. The smooth muscle constricts or contracts, and we call that a bronchospasm or bronchoconstriction. Then you're going to have secretions that are thicker and increased in amount. They're thicker, they're sticky, and they just plug everything up. So these can cause a partial or complete obstruction of the airway. In extrinsic asthma, the reaction is that type 1 allergic reaction we already discussed. This IgE on previously sensitized mast cells releases all these chemicals. That's where all of our inflammation and edema comes from. But there is a second stage to an asthma attack. A few hours later, leukocytes, which specifically eosinophils, increase and additional chemical mediators are released, and that prolongs the inflammation, the bronchoconstriction, the epithelial damage. This is why we give patients who are having acute asthma attacks, once we get them over that attack, we give them steroids for a couple of 2-3 days to relieve all that inflammation. And then we see air trapping in asthma. What happens is they breathe in. When they exhale, they can't completely expel all the air due to that obstruction. If you'll sit and think about it, normally expiration is involuntary action. We don't have to do anything. We breathe in and then automatically you exhale. But with asthma, that expiration doesn't happen all the way. So there's a little bit of left residual air in there, and that builds up, and that keeps them from getting a good air exchange. Eventually, those lungs will become hyperinflated, and we can see that on x-ray. A total obstruction can lead to hypoxia and respiratory arrest. If someone is non-responsive to therapy, we call it status asthmaticus. So our etiology is usually you're going to see there's a family history of eczema, hay fever, asthma, but now we're kind of seeing lifestyle. Kids don't go outside like they used to play. So they're indoors, there's poor ventilation, there's increased exposure to allergens indoors, but there's also increased pollution if they do go outside. There were actually studies that have shown inner city kids have higher rates of asthma because of the cockroaches. Cockroaches, their feces, it can really trigger asthma and cause asthma. So some of our signs and symptoms I think you all know the typical signs and symptoms of asthma. There's a cough. There's marked dyspnea. As the obstruction begins to get worse, they get agitated and they may not be able to talk. Wheezing is usually expiratory. You can hear it as they expire. It can be inspiratory as well. The thing you have to watch for is that if they're not moving any air at all, they're fixing to shut down on you and stop breathing, you may not hear any wheezing, but you're not really hearing any air movement either. So you're going to see rapid labored breathing. You're going to see use of accessory muscles. That means that they're using everything they have to breathe. They're sitting up. They will not lay down. They'll take a position of comfort and don't make them lay down because they'll quit breathing on you. When you raise their shirt, you'll see retractions where they're in between their rib area that skin will suck in. Those are called intercostal retractions. This mucus is going to be thick and sticky. They're going to have tachycardia. They're going to be working really hard. They're going to get hypoxic. They'll end up in respiratory alkalosis because of all the extra breathing, and then it'll turn into acidosis. They're going to be in severe respiratory distress. They will end up hypoventilating eventually because they're going to wear out their muscles, depending on the size of the child as well. Smaller children don't have developed musculature to continue to breathe like this. So they're going to end up in respiratory failure. Treatment. In a non-emergency situation, we're going to do allergy testing. What are they allergic to? Let's avoid those things. Stuffed animals, the dander from a pet, we may have to get rid of the pet. We may have to stay off of the grass or take medications before we go outside. For acute attacks, we want controlled breathing. Sometimes we have to have them purposefully breathe out through pursed lips, kind of like we do with people that have COPD. Inhalers. Albuterol is a beta adrenergic. I can't say it. It relaxes the smooth bronchial muscles. It works great in an emergency situation. Glucocorticoids. We can have inhaled or IV steroids. Inhaled is going to have less systemic effects. For status asthmaticus, we're going to have to treat them a little more aggressively. They're going to have some epinephrine. They're going to have steroids. And depending on their ABGs, we may have to ventilate for a while. If they've worn out, their muscles are just, they can't continue that. They just may need just a little help for a little while. And usually it can be reversible, but it can lead to cardiac arrhythmias as well. It can be fatal, so we have to really treat them aggressively quickly. And then for prophylaxis, if we want to reduce the amount of times they're in the ER, the times they have to be on steroids, leukotriene receptor antagonists are great. Montelukast, which is Singulair, works to block that inflammatory response from those mast cells. Works really well. Then in your text also lists cromolyn sodium as an inhalation drug. It also inhibits those mediators release as well. So that's it for this chapter. We'll see you next time.